Good morning. Welcome to meeting number 3 of the Budget Review Subcommittee on Human Resources. As a reminder, remote access is allowed to all meetings for the 2021 interim session. Members were provided a Zoom link to access the meeting remotely. The meeting materials were put online earlier this week and made available for downloading. At this time, we'll have the Secretary call the roll. Members, you will need to indicate whether you are present in person, remote from district, or remote from office.
Senator Rocky Adams. Senator Alvarado.
Present in the room.
Senator Berg.
Present in the room.
Senator Carroll.
Present in the room.
Representative Bowling.
Present in the room. Thank you.
Representative Frazier.
Present in district.
Thank you, ma'am. Representative Prunty.
Present in district.
Thank you. Representative Sheldon.
Present in district.
Thank you. Representative Weber.
Present in the room.
Representative Westrom. Representative Wilner.
I'm here in the Capitol Annex.
Thank you. Senator McDaniel. Representative Petrie. Representative Reed. Representative Moser. Co-Chair Meredith.
Present in the room.
Chair Bentley.
Present in the room. For people who are remote, please mute your microphones. We had a little background there, so we'll do it now. We don't have to worry about that later. So after calling the roll, we need to approve the minutes from the July 7th meeting. I heard a motion and a second. All in favor of the minutes, say aye.
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 And, okay, so they've been approved. Okay. So the approval of the minutes has been done for the July 7th, 21 meeting. Before we begin with the presentations, for members participating remotely, I will again ask you to mute your microphones. This morning we have Dr. Sarah Vanover from the Department of Community-Based Services. She will provide an overview of the $763 million in federal funding that Kentucky has received for child care providers. Dr. Vanover, please identify yourself for the record. Members, hold your questions until after the presentation, please. And each presentation today gets 30 minutes. So we ought to be out here before 12:30. So if we do 30 minutes each and some questions, it'll probably be an hour and a half, correct? Okay. So, overview of the American Rescue Plan Act.
Thank you so much. My name is Dr. Sarah Vanover, and I'm the Director for the Division of Child Care, part of DCBS and the Cabinet for Health and Family Services. I'm also Kentucky State Administrator for the Child Care and Development Block Grant funding that we receive from the federal government every year. Today, I'm going to give a presentation on our plan to distribute the American Rescue Plan funds to child care programs and to benefit child care programs throughout the state. Hold on one second and I will screen share with you. Can you all see that yet? Let me try one more time here. All right. Here we go. So during the course of the past year, Kentucky has received several different funding streams from the Federal Office of Child Care in order to support child care programs during the pandemic. The American Rescue Plan has given more funds to child care than we have ever seen in the state of Kentucky or throughout the U.S. in one single stream of funding. So Kentucky was awarded just over $763 million that is specifically designated to go to child care. These funds came through two different pots of money and had very specific restrictions on how those funds were to be spent. The largest pot of the money was $470 million that is specifically designated to sustainability or stabilization payments for childcare programs that are already open. Another $293 million is designated through one-time child care and development block grant funds. Of course, we receive annual child care and development block grant funds that the primary purpose of those funds is to support at-risk families and to run the programs that we already have established within the Division of Child Care, such as our CARES background check program and things like that. But these one-time funds have been given separate goals. The goals of the federal funds for the stabilization payments is very focused on supporting the programs that have survived the hardship of the past 17 months. There was a cutoff date for those funds and when the programs had to be open, and it really is looking at childcare programs that were open during this time period and suffered loss because of the pandemic and different things that they have been through. The one-time CCDBG funds.
Doctor,
yes.
Could you full screen your presentation? We're having a hard time reading it.
I certainly will. I'm sorry about that.
I was reading it off the paper, but some people are reading it off the screen. Thank you.
Okay. Is that better for you?
Yes, ma'am.
Okay. The one-time CCDBG funds, we were given very specific goals from the federal government, and that includes increasing provider payments, improving payment policies, increasing wages for our child care providers, specifically in centers and in family child care homes, and building the supply of child care for underserved communities. And this is kind of a broad terminology, but it includes children in these underserved populations by race, ethnicity, children who are diagnosed with a disability, children who have experienced trauma, infant toddler care, families experiencing homelessness, lots of populations that are at risk. There is a lot of accountability through the federal government attached to these funds, which makes sense due to the large amount of funding that we will receive. Starting 4 months ago, myself and the Assistant Director of the Division of Child Care meet with our federal liaisons monthly to describe how much of the funds we have spent, what types of projects have gone to that, and how many children we anticipate were served by that. We will be audited throughout the 3-year time period, pending that funding goes to the expenditures. All right, let me rephrase that. We'll be auditing child care providers throughout the 3-year time period to make sure that funding is being used for the allowed expenditures. We're also collecting monthly data that will be used for the Federal Office of Child Care Liaisons, looking at things like the overall anticipated budget of the centers. And there will be federal audits eventually that will include review of the funds and audit of random child care providers. We will be using a third-party company to help us with our auditing to not only make sure that the stabilization payments were used accurately, but also the other projects that will be funded through the one-time funding projects. So here's more information on the stabilization funds. We are anticipating 9 stabilization payments to child care programs throughout Kentucky, beginning in November 2020, pending the approval of the third-party contract. We currently are putting out a request for proposal to help us find a third-party company that will distribute all these payments, particularly because of the workload associated with it. Right now, we still have an additional CRISA payment that will be going out through the end of August. So childcare programs are still getting funding every other month through the last round of federal funding. Dividing up the funds into 9 payments, we'll be distributing approximately $49.6 million in each payment segment, and that will be divided amongst the childcare programs. Now, in order to participate in this, the child care programs had to be open and serving children prior to March 11th, 2021. And it's any regulated program, so it'd be licensed centers or certified registered family child care homes. They do have to participate in the All-Stars program. They can be at a level 1, which just means that as a level 1 child care provider, they meet the minimum state requirements and they have read through the expectations of the All-Stars program. They do not have to move higher than that in order to receive the stabilization programs. The main reason for that is that these funds must be used for centers that are eligible to accept children in the subsidy program. And in Kentucky, to accept subsidy children, you have to be part of the All-Stars program, as according to the regulations. We're looking at a multi-tiered system for how to distribute these funds. Throughout the pandemic, up to this point, we have used the maximum building capacity as the main tool to divide the funding. And we're still going to use that as a base. But during this funding process, we're also going to try and stimulate wage growth or to support programs that spend higher wages on their programs by giving those programs additional funding. Because as we know, if the program pays higher wages to their employees, then they're obviously going to spend more. So the base tier, tier 1, means they meet labor cabinet requirements, minimum child care requirements, and they participate in the All-Stars program from level 1 and up. Tier 2 would receive an additional 10% funding above base capacity, but they would have to pay all of their employees a minimum starting pay of $10 an hour or higher. And then tier 3 would pay an additional 20% over the capacity wage, but they would have to have starting pay at $13 per hour or higher. This stimulation, again, has a lot to do with the requirements of the federal funds, and that we are trying to increase wages for child care providers. It also has to do with the fact that right now, the staffing shortages across the country are primarily attributed to the fact that childcare is a very low wage field, despite the fact that it is an essential service and that our teachers do a great deal of work. Many of them in Kentucky still make close to minimum wage, and we need to be able to stimulate those wages higher in order to attract the employees to the field that we need in order to support the workforce throughout the state of Kentucky. So stabilization funds, according to the federal government, have been broken down into 6 different allowable expenditures. The primary expenditure that we are encouraging centers to utilize these funds for includes personnel costs, employee benefits, premium pay, and costs for recruitment or retention. So right now, while we're struggling so desperately with getting the staff that we need throughout Kentucky, these funds can be used for hiring bonuses, retention bonuses. Congratulations. You have worked with us through the whole pandemic. Here is a bonus to tell you we appreciate you. You've been here 5 years, 10 years. Thank you for your service. And of course, hiring bonuses right now can be a great way to get people in the door and get them in the center to work and let them see how much they enjoy working with the children and being a part of their care and education. Other expenditures include rent or mortgage payments, utilities, insurance premiums, facility maintenance or improvements. We're also continuing to pay for PPE, sanitation supplies, and professional development that is focused towards health and safety, which is still a huge need as we continue to fight illness throughout the centers. Updates to equipment to respond to COVID-19 if that a lot of this relates to health and safety equipment. We've had centers throughout the state, throughout the nation that have had to replace things like paper towel machines in the bathroom to put in hands-free dryers, or things that would reduce the amount and spread of illness throughout the center. And these funds would be able to support centers like that. New ventilation systems that purify the air, things of that nature. Goods and services necessary to maintain or resume services. So this really relates to food expenditures in order to feed children, consumables, construction paper, glue, scissors, the things that children need as part of their learning environment. And then this is new this round of funding, and really a great need is mental health supports for children and employees. So this could include curriculum very specific to social and emotional growth for the children within the centers, but also mental health supports for employees, bringing in somebody to do training with the staff on how to cope with the stress that they've maintained, or teaching resiliency, those types of efforts that would help employees feel safer staying in their position and support the children that may have elevated stress levels themselves after the past year and a half. Now, the other bucket of funding is CCDBG one-time funds. And like I said, typically the Child Care and Development Block Grant funding that we get in Kentucky is really focused on helping families that are at risk, families that have low income. This particular round of funding is focused on helping all child care programs through efforts like serving those underserved population, increasing wages for child care providers, and getting payments higher. So there are several projects enlisted throughout this funding, the $293 million. And I'm going to give you a brief description of these projects. One of them is a preschool partnership program that we will be doing in partnership with KDE. Now, we did something similar to this in Kentucky several years ago. The General Assembly put money in the budget for KDE to do a preschool partnership program. And where we look at the public school system has 3 hours of preschool service per day, typically for their programs, for children who have low income or children that have a diagnosed disability and already have an individual education plan. However, that 3 hours can be very challenging for working parents because many of them don't have the ability to leave work in the middle of the day and relocate their child to another area. So the last preschool partnership grant gave the public school system the ability to partner with local childcare programs that would extend the full day care for the children so that they would have the support that they needed and the partnership with the public school system. This is really essential for a lot of our kids with disabilities. Many children with disabilities do not get the support that they need from Kentucky's childcare programs because the teachers are not necessarily trained as in depth as the public school personnel are. So working in conjunction with them and having the public school system provide them with professional development can be a huge asset to the childcare programs and to the children. So this program currently has an RFA out. We're receiving applications for school systems that want to participate for the next 2.5 years. And it would help to extend the 3-day preschool day out into a full day by partnering with private childcare programs in the area with the public school system. Other areas that will receive some of the CCDBG money, there will be another increase to CCAP. We've just implemented the rate increase that was approved by the General Assembly in the last session. And now we would add additional funding to that for the length of this time period. We're also looking to address the benefit cliff by extending the window of time period that some families will receive CCAP. So currently, families graduate out of receiving subsidy when they hit the federal poverty limit, 200% of the federal poverty limit. And they go from receiving a large amount of subsidy to none within a month time period. We're going to extend a benefit cliff for 3 months where the families that graduate out would receive 50% of their typical reimbursement before going to zero. That way the family can ease out of the program, learn how to do that budgeting, and potentially not immediately return to the subsidy program within months after not being able to handle the large adjustment. Another subsidy-based program that we're looking at is an infant toddler pilot program. Currently, within the state of Kentucky, our subsidy program allows a family to receive a certificate of eligibility for subsidy, and then they go to a center and try and find a center that will accept subsidy. And then if there's an available slot, they can try and get in. Many times high quality programs are already full. And so children in the subsidy program, they struggle to get in. And this is really the case with infant toddler programs, since it is very challenging to find infant toddler programs in general. Centers typically, because the ratio is lower, in Kentucky, for example, 1 adult may watch up to 4 infants, whereas 1 adult can watch up to 12 3-year-olds. So infant toddler rooms are smaller. It's hard to reserve those spots. Other states have been very successful at having contract slots within an infant toddler program, where the state contracts 5 slots in that program. They pay for those 5 slots each month, and they must be reserved for children who are on the subsidy program. And when one child leaves, they bring in another child who is on subsidy. It wouldn't be the entire enrollment of the center, but it would reserve high quality spots for children who are already at financial risk. In order to be a part of this, again, there will be an RFA that goes out, and centers will have to apply to be a part of it. They will have to be a high quality program, a 3, 4, or 5-star program, because the goal of this is to take our most vulnerable populations and give them access to high quality programs where in the past they haven't had access before. The program will work with Division of Child Care to see how many slots that it can offer reasonably to reserve for children on subsidy. And then enrollment will be audited to make sure that those paid slots are not being wasted. Another program that we are looking at with the CCDBG funds is facility repair. This is something that often childcare programs do not have the ability to do. They don't have funds reserved for facility repair, particularly when it can be a large one-time fund. Many of the facility repairs, things like roof repairs, HVAC system issues, hot water heaters, can be a health and safety risk to the children that are in care. This grant would allow all programs in the state that are licensed or regulated in some way, family child care homes and centers, to submit an application with a current labor quote for a facility repair issue, and they would be able to get that repair made to their facility through these one-time funds so that the facility continues to be a healthy and safe environment for all children. Another project, we have several projects that are going to focus on workforce development as we try and make sure that child care providers make higher wages. One of the things that we also need to do is to stimulate their education and expertise in the area. So we have several workforce projects that we're going to launch with this money. One of them is a trainer academy. In Kentucky, we have credentialed trainers that are able, they go through a training process, get a certification, and then they have the ability to train our child care providers every year on the 15 mandatory hours of training that they must receive. We are going to be creating 2 trainer academies for these credentialed trainers. Up to 50 credentialed trainers can participate in each training academy, and they will each have a very specific training focus. One is going to focus on skills on how to be a director, things like marketing, how to use the federal food program, interviewing and which questions you are allowed to ask, which questions you're not allowed to ask, going through a lot of the basics that directors need. In the field of childcare, I will say that a lot of times the best teacher gets promoted to be the director. And they're very knowledgeable about childcare and development, but they may not have a business background. And that's why sometimes centers are more fragile. And so we want to make sure that these skilled early childhood experts also have the business skills that they need to make their program productive. And so this training academy, we will train all these trainers, and we'll make sure that there's representation through all 8 regions of Division of Child Care. And then the trainers will go out and train child care providers throughout the state on this content after they have been given these free trainings. The other training academy will focus on children with special needs and how to support them in the classroom. And again, this could vary from children and families experiencing homelessness, children that have mental health needs, children with specific disabilities, and the trainers will really become experts in this area. They'll be given a lot of resources, and then they will go out and train the child care population. When they submit their application to be in the training academy, they are signing on to do 2 years full of training in their area, in their region, and to make sure that these trainings are financially accessible to all people in that area. Another workforce development project that we are going to be doing is dedicating funds to the Kentucky Apprenticeship Program. Now, for early childhood apprentices, this program is actually supervised through the Governor's Office of Early Childhood. So we will be contributing funds to their program that is supervised by Brenda Hagan. And she will be finding ways to support and grow the Kentucky Apprenticeship Program. Right now, their office is looking at apprenticeships for preschool teachers, infant toddler teachers, and director apprenticeship programs. The money that we are giving to them will assist with all the fees for the certifications they'll get during the 2-year apprenticeship program, things like a child development associate certificate, orientation fees, first aid and CPR fees, or any other certification in their program. Now, currently, we have both youth and adult apprenticeships that we're looking for in this area. Youth apprenticeships are partnered with high school students, juniors and seniors in high school, that'll be doing their high school education at the same time. But the adult apprenticeships could apply to students that are going to college coursework as well. So the cost of the funds that we're contributing to the apprenticeships could help cover the cost of college coursework. The funds will also be utilized to develop a coaching model, a unified coaching model throughout the state so that all of our apprentices are getting the same content, curriculum, and coaching as they go through this program. Kentucky's early childhood apprenticeships are very new. They really have just started to be developed in the past couple of years, and this is a great way to get in on the ground building of this and make it a successful program for students to graduate from high school ready to enter the workforce, and for adults to specialize their skills. The other workforce program that we are dedicating money to is the Kentucky Scholarship Program for Early Childhood Educators. Now, this has been a program that has been in place many years. I can remember it being in place when I first started in the field 23 years ago. It was started with the Kids Now program that Governor Patton put in place. Our office has housed this program, and we've typically used tobacco master settlement funding for this. With the next 2 years and the funding that we've received, we can increase the amount of scholarships and increase the amount of funding. The scholarship money that was initially put in place, the rate that we reimburse at really has not changed in the past 23 years, although college tuition has gone up significantly. So during the next 2 years, we are going to look toward covering the full cost of candidates in this program, whether they're getting a non-college child development associate's degree or getting an associate's or bachelor's in early childhood education. We're also looking at finding a way to help administrators in the field of early childhood education pursue a master's in early childhood special ed or early childhood education throughout Kentucky state programs. The current requirements for this do require that a child care provider work in a center at least 20 hours a week, which often meets their curriculum and observation hour requirement to be in these programs. But this would help a lot of our providers to really increase their education, therefore benefiting our children a great deal and helping these providers stay in the field longer because they're well trained. One of the reasons that we see a lot of turnover, aside from wages, is that providers often don't feel prepared to deal with a classroom full of children, many of which may have special needs. So this workforce development can help assist them in feeling more prepared, as well as stimulate wages for them because of their new education level. One of the things that the federal government highly encouraged with these CCDBG funds was increase of data and technology systems. So there are several different projects that we're looking at for this. Right now, the Division of Child Care has 4 data systems that we use on a regular basis. One is the CARE system that does our national background check program. One is a professional development registry that is run by EKU as a contract partner for the Division of Child Care. We have the system through the state, Kentucky Connect, that helps families apply for subsidy and then gives us the necessary information we need to know who is in the subsidy system. And then we also have a system that has all of our licensed and certified programs listed in it and helps parents look and see what kind of ratings those programs have gotten, and gives us basic information on hours of operation, how long they've been licensed. You can look at past licensing reports, all kinds. A couple of these systems talk to each other. The EKU database communicates with the background check database, and the Kentucky Connect communicates with our childcare licensing database, but all 4 do not communicate together. And because of that, there are some data holes that we're missing. Currently, right now, there are data holes like being able to pull information on the racial, ethnic background of all the children we're serving through subsidy. Are we reaching at-risk populations? Are we serving all the children to the best of our ability? And also, we have holes on the providers that we're working with. Who are the providers that we know are making low wages working in these jobs? Is it just minority populations? Are they the vast majority? How do we support them more? And so connecting these database systems can give us a lot of necessary information about the families we're serving. But it also can give us information like, okay, if a center has a certain level of enrollment, that they have open spots, and we could put that into the parent search engine, then they could be able to search based on which centers have open enrollment instead of going to 15 centers that have wait lists. And so there's a lot of information that we're trying to put together in order to serve the state to the best of our ability. Another technology update that we're looking at is to provide all family child care homes and centers in Kentucky with a computerized enrollment and billing system. So we know from research that one of the main reasons that centers are financially unstable in childcare is that many childcare providers feel uncomfortable collecting tuition. Many of us went in the field because we want to help families. I know that was my initial goal, and going to a family and asking them for money when you know that they're struggling with it can be a very difficult thing for many providers. We know that when child care programs have a billing system in place that does automatic billing, that they receive more of the funds that they need to collect and have less of those awkward conversations, and their businesses are able to run more successfully. Also, with computerized enrollment, Centers would be able to more easily identify enrollment numbers and provide that information to the state so that we could assist with marketing as well. Other things that we need to consider is if we do all these technology updates, many of our childcare providers do not have a computer system that is up to date that could participate in these types of new systems. And that's a need. Many of our childcare providers throughout the state still use paper and pencil. This past year, we've seen the need for, paperless billing, paperless attendance, different things that childcare providers could access if they had up-to-date technology. And so a lot of these technology needs, they fall in line with a huge portion of the federal policy requests that align with the bill for the American Rescue Plan. And it'd help our centers to not only be more functional in their business needs, but also to be able to market more and for us to be able to serve the populations that we need to. For
Excuse
example,
me, Doctor. You need to speed up your presentation a little bit. You got about 5
Okay.
more minutes. Thank you.
Okay. The last area that we're looking at is startup fund grants. And we're looking at startup fund grants not only for family childcare homes, but also for potential new businesses. If they wanted to start an employee-based childcare, we could do a financial match with them up to $100,000. And the same for new centers in childcare deserts. I did want to give you just some brief information. We began the pandemic with the idea that national data showed that we could lose up to 40% of our childcare programs. Any loss is great, and I want to stress that again and again. The Kentucky has been able to limit our loss to about 8.9%, and we started at about 2,200, and we are right now at about 2,027 centers and family childcare homes. We started the pandemic with about 29,000 children enrolled in CCAP. There was a huge drop in the middle when families lost jobs. The numbers are now climbing again, and we have about 25,000 programs in the subsidy program, which means those parents are reentering the workforce because they have to work at least 20 hours a week in order to receive subsidy. So that's a good sign on our end. We have temporary regulations that have been put in place to increase the CCAP rate that was passed by the General Assembly, and also per the 2021 Senate Bill 148, we have new emergency licensure regulations coming into play so that we can be more prepared in the case of regional or statewide disasters in the future. And we have increased our number of family child care programs and are working to help lessen zoning barriers for starting up new programs throughout the state. Like I said, the CCAP increase went into effect July 1, and we are now billing for that increase this month. Providers will see that new increase. Challenges moving forward, our biggest challenge is increasing wages so that we can acquire the staff that we need. Also providing high quality programs for children with special needs, like in the preschool partnership areas. So I am now happy to take questions. Is somebody talking? I can't hear right now.
It's good. Thank you, Doctor, for your presentation. We'll take questions from the people in the room first, and then members participating remotely. Please use the chat function available on your screen, and the staff will notify the chair that you have a question. So now we'll start with Senator Meredith.
Thank you, Mr. Chair. Let's go to slide 8, if we could. Excuse me, slide 7.
I'm going back. Hold on just a second.
Okay, while you're doing that, I'll frame my question. Just trying to understand the structure of this, that there'll be a base payment for each provider, plus the add-on for additional increase in wages. Is that correct?
That is correct.
Is that base payment the same for every provider?
The base payment will be the same. Now, because we don't know yet which tier everybody will apply for, we don't know what the base payment will be. Once the applications come in and we see where the different tiers are, we'll be able to divide the base payment. I can say that the largest payment we've distributed lately was $300 per child at the beginning of the CRISA Act, and that cost $42 million to do that. We're starting off with $49.6 million. So we have a large sum each time. And then based on which tier the providers choose to be in, we will increase slightly, but we're using a capacity-based system. A lot of other states are only allowing some programs to apply, or they're only approving some programs. They have to write essays and narratives. We are really trying to support all Kentucky child care providers so that we preserve all enrollment and capacity throughout the state. And the capacity-based system we've used to distribute the funding has really supported that. But also we know that if a center is paying $9 an hour versus a high quality program that's paying $13 an hour, you know, there are higher expenses for that higher quality program. And we want to encourage high quality, not penalize that.
Yeah, I think we certainly do. And, I think you got a very ambitious plan here, and I'm very supportive of it. I think there's got to be some recognition, though, of that urban-rural disparity. The fact that rural providers may be paying less doesn't mean they're offering less quality service. It's just that the economics of the situation dictate something entirely different. And I certainly understand this, but I am curious as to what your thinking is in terms of long-term financial stability once these federal dollars disappear. If folks have increased their wages and suddenly they can't sustain that long-term, what happens then? So have you all given any thought as what the budget implications of this is going to be long-term? Because, again, this is budget review for human services. And, again, I applaud your initiatives, but want to make sure that going forward that we've got some long-term financial stability, or at least some plan for that. So is there a plan?
Well, first of all, let me say that rural programs will not be penalized by this because the same rate is going to be used throughout the state. So if nothing else, rural programs will get the same amount of funding that an urban program will, and it could easily help stimulate those programs that may have suffered other financial loss in the past. As far as thinking long-term, now programs don't have to apply for the 2-tier or 3-tier. So that is an optional program. A lot of the programs that we expect to be in the 2-tier and 3-tier are already at that rate. So they're already paying their staff a base pay of 10 or a base pay of 13. If programs choose to move up, they can do that and we can reimburse them for that. But they can also stay in tier 1 and use the money to help provide one-time stipends or other initiatives for the employees in a temporary sense. Now, we have looked at a lot of national data. I've talked with other states on distributing this. New data has just come out from the National Association of Education for Young Children, surveying over 7,500 child care providers throughout the state. And the big question to them was, what happens if you get a raise during this next 2 years? And for some odd reason, the program was not being able to sustain it. 73% of early childhood educators said that they would want the compensation to increase temporarily for the next 1 to 2 years, even if they knew that it would not be able to be sustained and would burn, because most of them are experiencing additional financial hardship at this point in time that they need to recover from. The other thing to consider is that we are collecting a lot of data during this process. We're asking centers as they get these sustainability payments to return data to us on their enrollment, their turnover, and several different key pieces of information that will give us a lot of traction with federal government, with state information to show that when wages are higher, the providers are more likely to stay and benefit children long term. And if we can use that data to continue to talk to the federal government about long-term infrastructure, then that can help programs sustain these higher funds for a longer period of time.
Just for clarification, then you're saying that they have the flexibility within the system to pay this as a retention bonus rather than build into the base pay rate. Is that correct?
They can use it as a retention bonus, but they would be in tier 1 to do that. All the stipends are allowed as part of that retention stipend or the initial hire stipend. And some centers are purposely choosing to do that. They're not going to be penalized for that. They'll still be reimbursed at their program capacity. But centers who are already paying their staff at higher wages, we know that they have more expenses because of that. And so we want to reimburse them accordingly. But if centers want to take the opportunity now to increase, they can do so. Now, the federal government is requiring us to have a rolling application date. So if a center applied to be at tier 2 and then they realized a couple of payments in that was going to be too hard of a financial burden for them, then they could revert back to tier 1. So once they're in the system, they don't have to stay at that tier during the 9 payments. They can choose to move.
Just one final question, Mr. Chair, if I could.
Yes,
on
sir.
slide 17, you're providing grants up to $100,000 match to open up new child care facilities. Counties considered a child care desert. How many counties have presently been identified as deserts?
65 of the 120 counties.
Excuse me, how many?
65 of the 120 counties.
is there a geographic concentration of those that are deserts? Do we see more of it in eastern Kentucky, west Kentucky, or is it across the state?
It is across the state, but there's higher concentrations in rural areas, predominantly because childcare centers do not do as well there. Since families are spaced so far apart, it's hard for many families to drive to a center and be financially successful. And so in a lot of those areas, we don't have as many programs as needed. They often need to be placed closer to businesses in order to be successful. But family child care homes are much more successful in those areas.
All right. Thank you. Thank you, Mr. Chair.
Thank you, Senator. We're going to take 3 more questions, and the next will be Senator Carroll.
Thank you, Mr. Chairman, and Dr. Vanover. I appreciate the testimony. The child care model is broken. It doesn't work. And in my biggest fear, and I think it's just been touched on, is in 2024, we're going to be right back where we are now. And I'm afraid that depending on the federal government or the state government to sustain these dollars coming into programs, that's not a very good business model. I'm not sure a bank would loan money based on that business model. So it is a concern. And speaking as a provider, a fairly large provider in our region, we have already gone through some of these motions, and as far as raises, as far as bonuses, sign-on bonuses, we've already done it all, and they're still not coming. And it is concerning, and we can. I'm just not sure this is, and very grateful for the funding, and believe me, it's going to help. But I'm not sure that this is a problem that we can buy ourselves out of as far as the staffing issue. I think I told you we had a job fair the other day. We had 10 people show up for it, and we were already at the high end of pay for our part of the state, and now we're way above everybody else, and we're still not getting them. So there are many layers to this issue, and even though this is very much appreciated, it is the basic child care model in this Commonwealth that we need to take a strong look at. And if we're going to be serious about early childhood education, and we know that the data is there that tells us we have no choice. If we want our kids to be successful when they grow up, we've got to start at early childhood, and it has got to be an ongoing, committed investment. It has got to be a firm structure that is built to allow it to be a profession, to allow it to be affordable, to allow it to be consistent across the state as far as quality. Otherwise, we're just throwing money away. There are still centers that are babysitters, and we've got to get away from that model, and there has got to be an expectation that this is not we call ours Early Childhood Education Center. We've got to, as a society within our state, they've got to be schools. It's got to be a school. It's not child care, it's a school, and the kids are getting an education, get my grammar right, an education while they're at that school. And so the problem is this is short term, and I think everyone needs to understand that. But in moving forward, we have got to put some serious discussions into the model of child care, and we've got to reform that in our Commonwealth. And it's going to pay dividends, not just in the child care, but in our high school success rates, graduation rates, our testing rates, college. I mean, everything. It's got to start, and we know it. The data is there, as I said. So just a few of my thoughts on that. 2 quick questions. The starting pay for the tiers, does that just include the early childhood educators, or does it include other staff within the facility?
It would include everyone working in the facility, because everyone there supports the children, whether they're a teacher, assistant teacher, working in the kitchen. We're looking at stimulating the entire workforce of early childhood, even if they are not the person who's solely responsible for the curriculum.
Okay. And then we had talked about like outdoor play areas, playgrounds. Will the grant money cover items like that? I haven't seen that specifically listed.
If there's a facility repair issue, then that could be included for health and safety. If not, then we encourage providers to think, well, you're using this to stimulate your income. How do you use your other revenue funds?
Okay.
So there can be things that can be tweaked. We do have within family child care fencing for an outdoor area could be utilized for that. But as far as learning materials and things, that can be used to think about non-traditional classrooms, because again, outdoor play we know right now is a greater health and safety environment than indoor play too.
Okay. And I appreciate the work you do. I don't know how many of our legislators realize that Dr. Vanover has a very clear vision for early childhood education in our state, and we are fortunate to have her. She is always accessible, and that's as a provider and as a legislator. And we have a lot of work to do, and I'm glad you're there, and I appreciate your vision and the work that you have put in on it. Thank you, Mr. Chairman.
Thank you, sir.
Thank you.
Representative Bowling.
Thank you, Mr. Chairman. I'm going to follow up. First of all, Dr. Vanover, thank you so much for the work that you do. It does not go unnoticed, and we're very appreciative of that on this important issue. But to kind of fall in line with Senator Meredith on the tier system, back to slide 7, I am worried about that rural-urban divide as well. I know I heard you say that it will have no effect on rural providers because they'll be in that first tier. However, when you have a finite amount of money, and you have X amount of dollars going out to fund that extra 20% and X amount of dollars going out to fund that extra 10%, at the end, you're going to have to lower the base, basically the base rate, just so that everybody can get the same. Is that not correct?
Well, here's what I meant with rural environments. So if we set an amount and say this round of money, everybody is going to get $300 per child based on their capacity. So that doesn't go as far in urban centers, but in rural centers, it goes much further, because you may have, for infant care in Lexington, Northern Kentucky, Louisville, it may be $235 a week for an infant, and maybe $155 in rural areas. So we're seeing that the capacity system as a whole is benefiting our rural providers. Now, if it's going to be harder to get to that tier 2 and tier 3, there are other programs that can help them. They can utilize their funds for stipends as opposed to doing the overall wage increase. But there are other programs that are going to assist them a great deal through this process as well. Like a CCAP rate increase, it may go a lot farther in rural areas than in urban areas. So the system between the variety of packages can kind of even out how the rural and urban communities are going to benefit.
Okay, thank you. And one more question. I'm not familiar with, you'd mentioned that there'll be audits both on the state level and then from the federal government as well. What
Yes.
normally goes on when you find that the funds have been misused? What is the action taken? Where is the accountability on that?
Okay. So when all these funds have been given out to the providers through stabilization payments, started with CARES, CRISA, and now American Rescue Plan, each provider, the director of the facility or the owner, signs a contract saying that these are the legal intentions of the funding. And then, it can't be transferred to a third party. If you choose not to spend it all, you have to return it. And that they can only be spent on these purposes. The Division of Child Care has a claims department that specifically works on misuse of funding, predominantly for our CCAP program. But now as we move through this new round of federal funding, if we find that somebody has taken the funds and not using them appropriately, then that would go into the claims department. They would be able to audit the information and potentially have a claims hearing for the amount that was misused, and then they would be responsible for repaying that amount.
Thank you very much. Thank you, Mr. Chairman.
Thank you, Representative. Representative Moser.
Thank you, Mr. Chair. Thank you very much for this presentation. This has been immensely helpful in understanding where all these funds are going. I appreciate all the comments from my colleagues about the sustainability, and I think those questions have largely been answered. I really like this plan. I think that this is lofty. I love the preschool partnerships, and I think it really speaks to the one-time funding, which we know this is, and how do we best utilize this in terms of increasing or improving our infrastructure? And I think that this plan addresses that in the partnerships, in the infant toddler project pilots, and then the training academies. I really like the idea of being able to recruit and retain our workforce and provide them with some really good training. And I think that is a great incentive for really retaining quality staff. So do you foresee any sort of legislation or any assistance that the cabinet will need to address how to really put some of these programs, codify some of these programs moving forward? There's always a sustainability question and funding, but what do you see kind of coming down the pike in terms of what you need from us?
We will be doing another update to the child care subsidy regulation because the reimbursement rates are within the regulation. And so we'll have to update that again in order to increase the rates. And they will be significantly increased for the next 2 years. Again, child care programs would rather have the increase. Families would rather have the increase for a short amount of time than not have it at all. If you say, hey, for the next 2 years, you have to pay very little in child care while you get back on your feet. As a parent, I would take it because I pay for 2 kids in childcare. But we will be updating that regulation both with an emergency and an ordinary so that the rates will go into effect immediately, but the ordinary reg can go through the extensive open comment period. Most everything else is policy change. We are going to be collaborating with both the Kentucky Higher Education Association with the scholarships. We're collaborating with GOEC, the Governor's Office of Early Childhood, with the apprenticeships, and we're collaborating with KDE on the preschool partnerships. So those will be some policies that we'll work through with outside organizations. We're doing a lot of requests for proposals and a lot of requests for application to make sure that the contract agencies we partner with through this or the organizations that apply for these fundings is done strictly by the books. And so we have a lot of those RFPs and RFAs that are going through process right now. So there is a lot of policy involved in getting these things into place, especially since we have a time frame with which we have to spend the money, and we want to make sure that we are as efficient as possible. But I can say right now that Kentucky is doing a great job in comparison to other states who might not have even announced their plan and still have that deadline looming 2 years from now.
Okay, thank you. And it's probably too soon to ask this question. And I know that the funding is really slim when it comes to childcare, but any sort of offsets. Are there any programs that you foresee that have been funded in the past that will no longer be needed as we move kind of forward into maybe this new structure?
At this point, I do not. The programs that we have are all set in place by federal mandates by the Child Care and Development Block Grant. So the programs we have been funding will stay in place with our annual distribution from CCDBG, and these will just be in addition to.
Okay, thank you.
Okay. Thank you, Dr. Vanover. I'm sure there's more questions that you'll be available to answer, so we're going to move on. So you might want to stick around because some of the questions might come up later on.
Okay.
First of all, we have some young leaders of our country in our audience, the law clerks. So if you all wave at us, you're welcome to our committee, and we know you're the leaders of tomorrow, and we're glad to have you here. So thank you for coming. Next, we'll take an update from Commissioner Stack and others about the implementation of House Bill 129 from the 2020 session and funding for foundational public health programs. Commissioner and other presenters, please identify yourselves for the record. Realize that you only got about 7 to 10 minutes each. And again, members, hold your questions until after the presentations, please. So now we have an update on implementation of the 2020 House Bill 129 and funding for foundational public health programs. Thank you.
Mr. Chair, thank you for the opportunity to speak on this important topic today. I'm just going to introduce myself and the panelists, and then they're going to do the presenting. We have President Ms. Chamness, Ms. Jan Chamness, who is the Public Health Transformation Project Leader here at the Kentucky Department for Public Health. Over the last year, she has collaborated with local, state, national, public, and private partners to advance the critical work of public health transformation. She is also our Director for the Division of Women's Health at KDPH, and she was previously the local public health director for Madison County for approximately 23 years. We also have Ms. Sarah Jo Best, who is the local public health director for Lincoln Trail District Health Department, serving Hardin, LaRue, Marion, Meade, Nelson, and Washington counties. Ms. Best is the president of the Kentucky Health Departments Association, representing all 61 local health departments, serving all 120 counties in Kentucky. She served in numerous roles in public health throughout her 19-year career. And then additionally in the room, I believe you have Mr. Scott Lockhart, who is the local public health director for the Kentucky River District Health Department, serving Knott, Lee, Leslie, Letcher, Owsley, Perry, and Wolfe counties. Mr. Lockhart is also the past president of the Kentucky Health Departments Association. All three of these leaders are women and a man with whom I have had the great privilege to serve. And I look forward to the presentations that Jan and Sarah Jo Best will give you. And then all four of us will be here for your questions. So if I can hand this over to Ms. Chamness, she'll start with the first presentation.
Thank you.
All right. Thank you. And again, just a minor correction. I was the former director of the Montgomery County Health Department, so I don't want to misstate or misrepresent where I came from. Let me share my screen with you real quick. And can you see that?
We see you.
Okay. Let me go back here a minute. I apologize. And now, can you see that?
No.
Gosh. I'm so sorry.
Do we have this in our handout?
There we go, Jan. Just make it the full presentation.
Okay, I'm so sorry. And let me pull up where I can see my notes.
We have the handout if you want to go ahead.
Okay.
And this one. Everybody have it?
And do you see the
No,
full
I'm
presentation?
sorry. No, they don't. You have to get it up. I thought they did.
I had practiced this so well.
Yeah, Jan, we see all the talking points too. I'd probably just click the presentation button in the bottom right.
Okay.
There you go.
Thank you.
All right. Well, thank you again for allowing us to provide this update on the public health transformation. And I want to start by going back to just a review of the purpose of public health transformation. I think that most of you all are probably familiar with this original map seen in multiple news feeds across the state back in 2018, which represents the pension crisis, which is basically when the employer pension contribution rose exponentially, forcing many of our local health departments to react through layoffs or eliminating programs or face the risk of actually closing their doors. But there were other changes that really led to this financial crisis in our local health departments across the state. There were federal and state policies which allowed more Americans and thus Kentuckians to have access to healthcare coverage with both the Affordable Care Act and Medicaid expansion. And with such policies, while generally very good for our communities and our individuals, it redirected many of our individuals to a medical home or a primary care provider for many of those services once provided in the local health departments, like well child exams, family planning, women's cancer screening, just some of the unintended consequences that we've been faced with. The second reason that we want to move toward public health transformation is this idea of public health modernization. Over 25 years ago, the Institute of Medicine, now referred to as the National Academy of Medicine, established this framework for public health, which identified the three core functions of public health: assurance, assessment, and policy development, along with the 10 essential services of public health. And then a little later in 2016, the U.S. Department of Health and Human Services launched the Public Health 3.0 initiative, which was a call to action to really restructure public health in a way to address social, environmental, and economic conditions that affect health. And so really these two reasons led up to probably the most important reason of public health transformation, and that is because what we're doing now is really not working. As a country, as a state, as communities and individuals, we're not getting healthier. And we can't not change the way we're doing things. These rankings, new in 2020's annual report of America's Health Rankings, show that we are 48th in health behaviors and 46th in health outcomes. And so we all know that these are not acceptable rankings for our state and for our communities. And so public health transformation is really our own call to action to really work together to create a more efficient, sustainable, and accountable public health system focused on producing better health outcomes for all Kentuckians. And so it's really time for us to begin to simplify, focus, and prioritize public health. I think that House Bill 129 helped us do just that. It's also known as the Public Health Transformation Bill. It led to amendments in KRS 211-185, which prioritize specific programs into core programs like WIC and HANDS, which health departments have traditionally offered in health departments, programs relating to harm reduction and substance use disorders that are plaguing our state. And then also under core public health is this list of foundational public health programs, which we oftentimes refer to those programs as those that we're really legislatively mandated to provide. And then it allowed us to push some of these other programs into local public health priorities, giving local health departments options or being able to choose based on the needs of their community, as identified through a local needs assessment, some of these additional programs. Another part of House Bill 129 were amendments to KRS 211-187, which led to further definition of these local public health priorities and really established this whole set of criteria and these key terms identified in the statutes where we would have to provide some level of criteria or guidance for local health departments to choose to provide some of these local public health priorities. We now are looking for what is the data to support the need for these programs in communities. Are we using evidence-based and promising practice interventions within these programs? Is there adequate funding once foundational and core programs have been funded? Are these programs part of the local health department's performance and quality management plans? And this notion of an exit strategy, should the local health department determine that a program is either A, no longer needed within that community, or B, the local health department can no longer sustain that program, what is the plan in order to continue that, to offer that program? Is it partnering with other community providers to assure that those services are available? We've been very busy since House Bill 129 was passed. And one of the big challenges that we needed to really define for the Department for Public Health as well as local health departments were, what are those programs that fall into what we now refer to as the green box programs, this local public health priorities. And I want to make this clear right now. Don't misunderstand that these programs that are listed here are not important, because they're all important. It's just that we had to begin to prioritize what were those services that our citizens could expect for a local health department to provide through core and foundational, and then what are those programs that local health departments can choose to provide based on the criteria in KRS 211-187 and based on that local needs assessment within their community. I wanted to share with you just a high-level timeline of where we've been since House Bill 129 was passed. As you all know, it kicked off in early 2019. There was some initiatives underway to kind of help to continue to sustain local health departments keeping their doors open. But there were initiatives like white papers that a group of local health department directors worked with DPH to identify some programs that needed a closer look and identifying ways that might make them more efficient or effective in being provided in the local health department. But a public health transformation relaunch occurred last year in October of 2020. And yes, that was at the height of the pandemic. And perhaps even in spite of the pandemic, because we recognized that we had to push forward for this type of change. So we also wanted to make sure that when we relaunched public health transformation last year, that everyone understood that this was not an initiative targeted to local health departments alone, that we are all in this together as far as moving public health transformation forward, that this is both a statewide initiative as well as an initiative intended to assist local health departments. I'm happy to report that we really just concluded this very intensive planning phase, resulting in many successful changes, as I'll review some of those in just a few minutes, but also resulted in work plans which will guide us into this next implementation phase. I'm hopeful that the implementation phase will kick off later this month or in early September. We will have a new strategic plan that really guides us into the next 5 years using public health transformation tools in order to map out our strategic plan and moving forward. And all of this, keeping in mind that we're trying to create this culture of change where we're embracing change and not fearing change, and where we're really encouraging and welcoming collective input and not dismissing people's ideas. Again, this is just a visual of the organizational structure that we used in the relaunch of public health transformation. I think it shows how comprehensive and collaborative we have really tried to be. It was not intended to be an organizational chart or a hierarchy per se, but just a description of how we're managing the process. It is a work in progress. When we first started, we didn't have a budget subcommittee. We recognized very early on that we needed that because of some urgency in looking at the way local health departments submit their budgets in order to comply with public health transformation, House Bill 129. We anticipate that in moving forward with implementation, that we'll see work groups come, we'll see additional ones added based on what we're looking at, and we may see some go away because they've completed their goals and their action plans. I wanted to show just, you do have this in your packet because I know it's difficult to read, but I just wanted to emphasize here that Kentucky's Department of Public Health has really experienced a rich history focused on strategic planning. This actual map was adopted in 2011, 2012, and has been tweaked over the years. But I want you to know that the mission and vision has never changed. The 4 areas of people, quality, efficiency, and effectiveness, and building public health capacity remain the 4 cornerstones of our strategy and moving forward, and with integrating public health transformation into that. We did tweak it a little bit to provide just an emphasis of this overarching principle of promoting health equity in all we do, just recognizing that that's an important part of moving forward. And lastly, I just wanted to go over some key highlights of some of the work that's been done since House Bill 129 was signed into law. This is not an exhaustive list, but as I said, as I've indicated, we've finalized work plans during this intensive nine-month, 12-month planning phase that we've been in. I'm humbled to say that we had over 100 staff representing both the Department for Public Health and local health departments across the state involved in this planning phase. We identified the local public health priority programs, and the next thing we'll do is further refine what those look like in terms of that local needs assessment and all of those key terms and key criteria that need to be further defined. We revised the local health department budget review process for this year. Local health departments have most of them have submitted their fiscal year 22 budget for next year, and we are beginning the process of further refining and defining the process for fiscal year 23. As I've stated earlier, we've updated our strategic plan that really provides a map for how we go about providing public health for the next 5 years. We have ongoing public health transformation initiatives, really taking each program and being very intentional about just peeling back the onion of the programs that we've offered traditionally for years and determining their relevance. How do we need to change them or tweak them? Do they need to change at all? What does DPH's support look like for local health departments in moving forward? We have developed some enhanced communication tools to help us spread the word of public health transformation. We have a one-pager that we've shared with our partners, as well as a monthly status update that we provide. And we're working on a website that will be linked to the KDPH website where people can go and find out what's going on in public health transformation. And we're working on a video that we hope to have ready within the next month or so. We've designated a public health transformation team with a focus on performance management, accountability, and transparency, which after all, this is a quality improvement project of immense magnitude. And so we really want to be transparent as we move forward. We've not only enhanced partnerships, but we've forged new partnerships with new external partners like the Kentucky Primary Care Association and many of its members who represent rural health clinics and FQHCs across the state. We've increased partnerships with university and hospital-based primary care clinics, and that list is continuing to evolve. I just want to emphasize that we really are looking at public health transformation as a movement in moving public health forward in the state and focusing on creating this culture of change. I know I've gone through this really fast, and I'll be glad to entertain questions after Sarah Jo gives her presentation, but at this point, I'll go ahead and turn it over to Sarah Jo.
Miss Sarah Jo, are you there?
I'm here.
You have 5 minutes.
Oh, goodness. Okay. I will do my best. Okay. Are you able to see my screen?
Yes, widen it out.
Okay.
And
Right.
your equitable funding solutions is the most important slide you have, so make sure you cover it.
All right, I will. I will go through this very quick. My name is Sarah Jo Best, and I noticed in the audience, I want to give a shout out to Representative Mosier, because public health transformation would not be where it is without all of her work and her support. I also believe I saw Senator Alvarado and Senator Meredith, who were also instrumental in this. I want to thank them right off the bat. Kentucky Health Department Association is a professional association of health department directors across the Commonwealth. I currently serve as the president, as Dr. Stack mentioned. We also have gone over the fact that public health transformation was born out of necessity, both financial and the fact that we could no longer accept the fact that our health outcomes and our health behaviors were not moving the public health needle, if you will. So when we worked on public health transformation, we really focused on 3 legs of the public health transformation stool, if you will. The first was really the focused services, introducing that simplified public health model that we mentioned before. This also created collective impact, which will help with some of those. The fact that you've seen one health department in Kentucky, you've seen one health department. How many times have we heard that? The focus services assures every Kentuckian that when they walk into a local health department, they're assured at least the basic packages of services. It also looked at stabilizing the pension system as the second leg of the stool. That allowed for more manageable planning and budgeting for local health departments and provided the opportunity for us to add staff at normalized cost. And the third and the final leg of the stool was really equitable funding, as you mentioned, and that was creating an equitable funding formula for foundational or statutorily required services to ensure that all Kentuckians have access to a specific set of services, regardless of their zip code or tax base. So this is that model that you see, and I just wanted to draw attention to the fact that you'll notice that the remainder of my slides, I have check marks next to the actual items or goals of the broader categories of public health transformation. The check marks represent that significant work has been put into each of these, but with any goal, continued objective work and specific tasks are still being worked on, evaluated, and improved. So we're never going to be in a state where we're completely finished. We're always going to be focusing on quality improvement and moving that forward. So not only did this simplified, focused methodology of providing services increase our efficiencies, but they also assured that our resources went to these services first. So before we were a mile wide, we were an inch deep, we were trying to be everything to everyone. We could no longer do that. And so we had to make sure that our funding, or our resources, funding and human, were put into these areas first. And then as grants and things allowed, we could do these. And then as we had funding and people and needs in our community, we could focus on those green box items. And so there's been a lot of work done in legislation, specifically KRS 211-185, which Jan has mentioned before. But the other thing I want to draw your attention to that was work accomplished in this was the community health assessment. The requirement of community health assessment was long overdue, and as a result of this work is now included in 902 KAR 8160. That really provides accountability for programs outside the core package of services. Health departments must evaluate the need in the community through an assessment process using both qualitative and quantitative data as well as community input. And that helps drive where our resources go. And assuring that the statutorily required services are done first. It also challenged the local health departments to evaluate the resources for programs that may already be available in the community and really forged collaboration with community partners. So as you know, every fall, KRS would crunch the latest numbers and determine how large the unfunded liability was. And as a result of that, then we come up with a percentage of payroll that we would need to pay to keep the pension system liable for another year. So many public health many public employers really responded by decreasing their payroll, thus controlling their pension costs. And you can see that local health departments did that same thing. There was over a 51% decrease in staffing in local health departments from 2008 to 2020. So House Bill 8 was a component of this. It froze the pension contribution rate in statute, and that enabled local health departments to better forecast operational costs and the pension contributions for decades to come. This eliminated the constant uncertainty of the ever-changing ARC, stabilized the quasi-pension issue. It also provided the opportunity for us to bring new employees on at a normalized cost. But what I want you to know is while House Bill 8 did provide for better budgeting and was financially beneficial for 33 local health departments, there were 27 local health departments that saw their rates increase to 85% or above. These ranged anywhere from 85% to 300%. So it should be noted that there are health departments that will not be able to support the increase even after the loss of half of the subsidy, even through taxation. So currently we have 48 health departments that are above the state average of 4.72 cents per $100 of assessed property. 7 that do not have an established public health taxing district, 9 who have tax rates at 8% or higher, leaving them very little room for growth, and 2 who are already at the maximum taxing rate according to KRS 212-725, which is 10. Keep in mind that the counties with the highest rates are typically poorer, rural counties, some of which have declining property assessment rates due to losing populations and valuations associated with unmined minerals. Letcher County is an example of that. So this is the slide that we need to focus on. One, I want to say that we did some work on ensuring that fees cover the costs. So the evaluation of fees associated with environmental permits was also work done for public health transformation. Amendments were made to KRS 211-180. to allow for improved alignment of fees with actual costs of providing services. So that reduced the amount of public health tax dollars that were being used to support private business permits. Public health transformation identified a funding formula based on the cost of providing foundational services. It wasn't intended to cover all of the health department costs, only those statutorily required costs associated with those dark blue box services. The calculation is based on the absolute minimum number of employees needed to conduct statutorily required services, and that's based on the population size of the service area. Funding is based on average cost identified by the Cabinet for Health and Family Services through the Kentucky Department for Public Health in relation to health department coding, and include average expenses directly linked to providing foundational services such as salary, benefits, and operations. It also depends on the evaluation of the actual retirement cost for foundational employees. So after this total cost is determined, it requires that the minimum public health tax be dedicated to foundational services. It requires that the 90% of the fees retained by the local health departments for environmental permitting and inspections be subtracted from this cost, and also subtracts out any federal preparedness dollars received by the local health departments. The remaining expense is what should be included as an individual budget allocation within the state budget to each local health department in accordance with KRS 211186. Without this funding, these services become unfunded mandates. And as health departments need to further streamline services, lack of this funding may lead to the inability to provide core foundational services. I've included on this slide an example of what this formula looked like for fiscal year 22. Please keep in mind that these changes and per KRS 211186 shall be determined on or before May 1st of each year preceding a biannual budget session of the General Assembly. I also wanted to demonstrate the commitment from the local level in assuring that foundational services are provided. You can see that in this example, 83% of the funding for operational costs are locally funded. So in summary, public health has long served as individual guardians, working across all areas of life to protect and improve the health and people of our communities. Prior to the pandemic, many of the services provided by public health remain unfamiliar to most. In many ways, COVID-19 changed that. It's my hope that with all the lessons over the past year and a half, that we have the opportunity to learn, improve, and continue this important work to ensure that our public health system is based on a firm foundation, but also that it is nimble enough to respond to threats to our health and safety, and that is supported and valued by our communities. We look forward to continuing to work on public health transformation with all of our partners and improving the public health system for all Kentuckians. That concludes my report, and we'd be happy to entertain any questions you might have.
Did you have something you wanted to say?
No, I'm here for the Q&A. If you
okay,
need
we're going to start questions
to that.
then.
Very
okay.
good.
So our first question will be Senator Meredith.
Thank you, Chair. Appreciate the presentation. You know, personally, my 5 years here, I think House Bill 129 is one of the best pieces of legislation that we passed, and I'm very thrilled to see that Department of Public Health is taking this seriously in using the tools we've given to them. But I don't think it goes far enough. You know, if truly believe opportunity arises out of adversity, I think what COVID-19 has shown us is, again, the renewed importance of public health. It kind of taken a back seat, and we didn't think a whole lot about it until this occurred. And while we are making some tremendous advancements, I don't think we're going far enough. That quite literally, if we're talking about accountability for health care, public health is attempting to do it in a vacuum because they don't control the purse strings, which is the commercial insurance and our own Medicaid program. I always find it curious that we talk about funding for these things, but Medicaid alone, we're going to spend $14 billion this next year, and that's phenomenal. We know automatically 10% of that's going to go to the managed care organizations for the administration and profit portion. That's $1.4 billion. We can fund a lot of things there. You know, we talk about health outcomes in our state's position. We're 48th, 49th consistently. And the problem is that what becomes everybody's responsibility becomes nobody's responsibility. If we're truly going to improve the health of the population, it needs to be centralized in one group. And I think the Department for Public Health has that opportunity. Who's going to drive the train for improving health care in Kentucky? We've kind of delegated that in large measure to the MCOs. In the now over a decade they have done that. They have not improved the health of the population at all. They barely moved the needle. And Senator Alvarado have had numerous conversations about this. Why shouldn't the Department of Public Health be the managed care organization for the state? Invest in them the responsibility for improving the health of their population and bring everybody else in line. You know, the MCOs still have a role, not as MCOs, but the traditional role as insurance companies. Process the claims, but give the accountability for improving the health back to the people who should be responsible for it, and that's our Department of Public Health, that we can monitor on a local level with our local health departments. Why should we not do that? That's not a rhetorical question. I want to know, why can't we change this whole model to build in that accountability that we're talking about and have a better coordination of services than we've had in the past, have one centralized focus for improving the health? Should be the Department of Public Health. So why not?
Who wants the question?
Joe, why don't you start? Or Scott. Scott, you're in the room.
Scott, Senator Meredith, I appreciate that, and Senator Alvarado and I've had this conversation before too. I agree, it's all local, and my perspective as a local public health director, I'm starting my 31st year in public health. There's a lot of things we can do at the local level. And part of this public health transformation is the health departments are seen as conveners, getting all the players together and working together. So we stand willing and ready to work with the Department of Medicaid, with our legislature, with the Department of Public Health to make sure that whatever policies are passed, we're implementing at the local level for the benefit of all. So.
Well, I appreciate that, but I think everyone agrees we can't sustain the trajectory that we're seeing for the cost of healthcare in Kentucky or even nationally. There's a better way to do that. There's enough money there if we do it the right way, and we're not doing it the right way. Part of the issue is with the data. Everybody collects data. We're drowning in it, but what are we doing with it? Very little, at least not on a centralized basis. That goes back again to the Department of Public Health. And again, we have 120 counties, and I can assure you every county probably has a higher or a different priority for healthcare issues than others. But when we take a broad brush approach to this and just say, we're going to improve the health of the population, it's not going to happen unless we ratchet it down to the local level and truly identify the top 2 or 3 priorities that need to be addressed. And then once we do that, we can move on, and we've got funding for other things as well. That's not to minimize the other healthcare issues that we have to deal with, but until we take a laser and focused approach on this to truly improve the health of our population, we're just going to have these discussions year in and year out, and quite truthfully, I don't have the patience for that. So we know there are other models out there. They're very successful. Senator Alvarado and have had several conversations about this. We need to be exploring those, and we need to do it yesterday. Again, if we're not improving the health of the population, who's responsible for that? We can blame it on a lot of different people, but I always point to the MCOs because now 1.6 million of our population are under Medicaid. They're not doing the job. They haven't earned the pay. We need to use these resources more wisely than we have, and we're doing that. So, Dr. Stack, I would just encourage you, let's truly quit kicking this can down the road, and let's change the model. Let's do it different. Let's be a think tank for the rest of the nation. I know we can do this better than what we have been doing it, and we need to quit talking about it.
Thank you, Senator. I appreciate that, and I think the discussions that Secretary Friedlander and Commissioner Lee, have through some of the other committees, and obviously those of us as a coordinated leadership team at CHFS are happy to have those discussions and dialogue. So thank you very much.
Well, I'll just share with you my favorite riddle, and that's you got 5 frogs sitting on a log, 3 decide to jump in. How many are left? You got 5, because deciding to do something is not the same as doing it. We got to quit talking about it and do it. There's enough money there. Our state can't continue to sustain this growth in expenses. Neither can our business community. We have an opportunity to not only address the reduction in the Medicaid expense, but also make it health friendly for employers in this state. That would be a great recruitment tool for Kentucky if we can show that we have really developed a process that improves the health of our population, reduces their health care expenses. That could be a major selling point for bringing new companies to Kentucky. But we can't keep doing what we're doing. And sorry, Mr. Chair, I go off on that rant, but it's just Tired of talking about it. Thank you, sir.
I didn't stop you. Yeah. Thank you, Senator. Representative Moser.
Thank you, Mr. Chair. I really appreciate Senator Meredith's comments. I too believe that this is a real opportunity, and maybe this is the jumping off point. You know, we've started a really great conversation through DPH transformation, and I think this is really an opportunity to be innovative and really have those conversations about what is quality improvement, how do we get there. Kentucky's health metrics certainly have nowhere to go but up. And all of that being said, we had a great work group for DPH transformation. Maybe it's time to bring all those folks back together and have a deeper conversation. I'm certainly willing to do that. I know all of the experts to bring to the table. So, you know, we have a great starting point. But I want to thank all of you for really working so hard to implement and really have the hard conversations about what the DPH transformation meant. It was one thing to pass the bill, but a whole another thing to really get down into the details, and we certainly turned to all of you, our public health experts, to do that. And I just want to say thank you. Hopefully this is just the beginning of a larger conversation. So thanks for everyone's work on this.
Representative, if I could just add my thanks to Sarah Joes for the leadership you and Senator Alvarado and Senator Bentley and the others had. This model was one already in place before I became commissioner, and it was shortly after I became commissioner that the legislature enacted House Bill 129. And despite the strains of the past year, the fact that local health department leaders and Jan and so many across KDPH have come together and have decidedly attended to this and made it a focus and a priority, I think hopefully reflects the commitment we have to making a successful transformation, and to the points that multiple of you have made. If we want to improve the health of Kentuckians, we have to have a sustainable and successful public health system that gives every Kentuckian a fair shake, whether they live in a rural community or an urban center, and no matter what their circumstances are, it gives them a chance. And so I really do look forward to working with you, Representative Mosher and the others, and we're happy to dialogue.
Thank you, Representative Moser. Senator Alvarado.
Thank you, Mr. Chairman. And first of all, thank you all for your presentation. Senator Meredith kind of stole my thunder, but I'm going to jump on and be the lightning behind him. First of all, Jan, it's good to hear from you. I appreciate you being on. I miss talking with you. I know we've had a lot of discussions in the past. I know Scott and I have had a lot of discussions. And you're right, Jan. I'm glad you corrected Montgomery is not Madison County, so I appreciate that. I take a lot of pride representing Montgomery County and love that community and the health department that works so hard there to keep people healthy. Jan, I know you had your presentation, and I was just going to, again, I think reiterate what Senator Meredith said. Maybe Senator Meredith, what we need to do is take it upon ourselves to start drafting legislation. I know we often we've talked to a few administrations now about these ideas. Everybody says, let's talk. It's a good idea. Yeah, let's chat about it. Nobody wants, because they know it's going to be a sea change to make that difference. But for those of you who are wanting to watch what some national models are, Oregon has what's called the Collaborative Care Organization model, where they use MCOs and they use the health departments as the arms locally to determine what is needed in local communities, because what's needed in Jefferson County is going to be different than what's needed in Owsley County or in different parts of our state. And so every health department collaborates. But Jan, you kind of, on your presentation there, put up our 2020 annual report of where our health outcomes are, and we're 46th ranked. Does anybody know what our rankings were in 2010? I think we were 47th, is what I can find. We've gone up one slot. Yeah. We've rolled out the ACA, a bunch of MCOs, paid them billions of dollars with the promises that this is going to drive our health outcomes in a better way. We're going to do better. We're going to be moving up in those rankings. People are going to live longer in Kentucky. 30,000 new jobs. I remember all of those promises when that was rolled out. And you see where we've gone. In 10 years, we've gone up one slot. Not much has changed. MCOs who are claiming to do things, to manage a lot of the things. And again, Sarah Jo, in your presentation, I think you also put up, or maybe it was in I'm confusing presentations. There was one here about the issues that are important, the local health priorities, what Jan had presented also. All the local public health priorities in slide number 7 about, diabetes and nutrition and staying well biometric screenings. These are the things that health departments prioritize, what our MCOs are prioritizing. And for 10 years and billions of dollars have done nothing to move those numbers up for us in managing our health care. So I think Senator Meredith's point is correct. It's time for us to stop talking about this. We have RFP proposals that are being proposed right now. Maybe it's time to change our structure since we've given a 10-year trial and it hasn't worked. We're not seeing things improve in the state of Kentucky. The other thing also, Sarah Jo, I know you presented also on the 3 kind of parts of the stool. And I would propose maybe little bit of a different thought on one of those legs. I know we look at stabilized pension and focused services and funding. I think that one of those legs, probably the focused services, should be the seat of the stool. All these things are propping those services up to make sure they're offered to our community. One of those legs needs to be the people and the staff. And I know we're trying to attract more staff, and we're having discussions in other committees about the struggles that staff are going, the burnout that's going on right now in the world of medicine, the struggle to find providers willing to come in and provide care. We've got to find a way to recruit more people into public health, which is not the sexiest of avenues of healthcare. Not the most highest paid, obviously, we know that as well, but probably one of the largest impacts that we can have. And we've got to attract people to come into that, and that should be one of the legs of the stool, supporting the focused services that you all provide. I'm going to stress to the members of the committee how important it is for the funding for this bill. I know if you all could request it from your respective leadership that we need to prioritize this to make it go forward, but I think Senator Meredith and I need to sit down. Maybe it's time for us to start putting pen to paper, and it would be a massive bill, massive, huge, but having to start requiring this of our administrations to start looking at a different model. And I think it would be to incorporate our MCOs and require them to partner with our health departments, because the MCOs are good at data collection, but not at healthcare management. Our health departments are really good at healthcare management. Maybe don't have the resources for the data collection, but locally who has the needs, where the issues are, where the resources are, to start teaming up both of those together to start providing a better outcome for the state. Maybe start seeing that go from 46th to 36th to 26th, maybe even hopefully, and maybe high aspiration be the top 10 in the state in terms of healthcare outcomes. So I want to thank you all for your sacrifice, for the time, even when you retire, Scott, you can't stay away. I know you have to keep coming back, and that's just kind of the nature of the beast for those of us who are involved in this. So thank you all for the efforts that you put forward, and maybe, Steve, we need to start talking about looking at putting something together. Thank you, Mr. Chairman, for the rant.
Thank you, Senator Alvarado. I have one question. I have some comments, and we'll be adjourning. My question is on public health transformation. Will the additional general fund dollars be necessary to sustain the core public health foundation services in the upcoming biennial budget?
Yes. My short answer for that is yes, because of, I would just say that the health departments were very supportive of House Bill 8, but not in and by itself. One of the things that we were very honest about in the beginning is we really needed House Bill 129 to go through with the funding formula in conjunction with House Bill 8. We needed both of those things. So yes, that would still be something that we would need in the future.
Thank you very much. Now my comments are going back to Senator Carroll. I had 3 grandsons that went through daycare in Japan. And they think of education at that level as an education, as you say. I think we need to change our mindset on that. For they were taught how to clean the room, and they were taught how to cook for themselves. So when they came to the United States, they were ahead of their peers. So I had 3 grandsons who were educated over there. So I do know that. And Representative Moser, I never really ever give you a comment in public, but I do want to now. 129 was an excellent bill. It was a privilege to work on that committee. I sat beside Senator Meredith many times when we talked about it, and Dr. Alvarado. I think that's one of the best bills that I'm like Senator Meredith that's helped the state of Kentucky, especially in my region in eastern Kentucky. And those rankings, ever since I graduated from UK in 1973, we've always been in the 40s. That's one of the reasons I wanted to be a representative, and I carry that on my shoulders every day at home. I went back to Eastern Kentucky to be a healthcare provider and educate the people up there. You know, people coming out with diabetes and going out the door, they buy a Milky Way and a Pepsi. We've got to do better. And so I thank all of you, and I thank all of you for being here. I mean, this is really a great committee. We've talked about a lot of great things today. I agree with Senator Meredith. I agree with Senator Alvarado. And so just make sure we got good minutes from today. You know, my heart as an Eastern Kentuckian is for the whole state of Kentucky to improve their health. I mean, what else could you really have if you really love your fellow Kentuckians? Give them better health. So with that, we'll have Zoom link next time. Remote will always be able to be accessed. And the next scheduled meeting is September 8th. And so I ask for a motion to adjourn. Thank you.